audible?
Yes, audible.
Yes. So, welcome all to our sixth session. We will start off with presentation by Dr. Sunitha Daniel. We can have her presentation till 3:40. At 3:40, we will have a discussion on the same. And by 4, we can start our case presentation, followed by its discussion. We can wind up the session by 4:30. Happy Eid to all.
Thank you, ma'am, and wish you.
So, Dr. Sunitha Daniel, she's a consultant in palliative medicine. She has done her MRCP from internal medicine in UK and also in palliative medicine MRCP from UK. And she was working in Kerala, and she has come here and come to help us for 3 weeks, and she was with us for 1 month back. And so this is going to be a very important topic. So yes, difficult pain, and it's over to you, Sunitha.
Thank you, Dr. Sunil. Am I audible to you all?
Yes, you are audible.
Thank you, Rajlakshmi. Good afternoon to everyone. Dr. Sunil introduced, and Sunitha. I'll be going through the presentation with you for the first 40-45 minutes. Please stop me in between if you feel that I am not audible or if I'm too fast. And please let me know if it's not clear. We'll briefly talk about how to manage a patient with a difficult pain. Next slide. So in this 45 minutes, what I'm planning to do is a brief case study of a patient who's got a difficult pain. We'll be going through the patient with a 10-step evaluation of the process. In between, I'll be asking a few MCQs. When the question comes on screen, anybody who knows the answer can unmute themselves and tell the answer. It's quite straightforward. It's just to make sure that you're all on board with what I'm saying. We'll briefly discuss about neuropathic pain and the other adjuvants, medications used in neuropathic pain and the role of other adjuvants. To conclude, I'll be mentioning a bit about lignocaine and ketamine, and then we'll move on to the case presentation. Next slide. So we've got a patient whose name is Mrs. S. She's 67. She's got metastatic CA breast. She had post-RT, had post-surgery and post-chemotherapy, and she's been under us for pain management. Now, she complains of pain all over the body, and it's worse in the areas of bony metastasis. She's on diclofenac, but that's given her severe gastritis, and she's unable to sleep at night. And because of the severe symptom, because of the severity of pain, she's asking to be killed herself. She's asking for euthanasia, basically. Next slide. So we've been giving her some paracetamol because the diclofenac was not working. So we started with the ladder. We went with paracetamol, 650 TID. We've added on morphine because pain is so severe. We didn't go for Tramadol. We've gone straight away to morphine. She's on 10 milligram Q4 thoroughly, and she's on bisacodyl for the constipation. With this regimen, this step 1 and step 3, she's only got a partial pain relief. So next time when we saw in the clinic, we've increased the morphine to 15 milligram Q4 thoroughly. But Mrs. S is unhappy. She is not very happy with this treatment, and she does not want to continue the treatment due to various reasons. Next slide. Some facts about the pain. You all sort of must be aware that pain is probably the most common symptom that you, we as a palliative care physician usually face. And it's in number-wise also, it's very true. So 70% of patients with advanced cancer and 65% of patients from non-malignant disease have got pain at some time in their disease process. And if they've got pain, 1/3 of patients will have a single pain, 1/3 will have more than one pain, so it can be 2 pains in different parts of the body, different reason, and 1/3 might have 3 or more pain. So pain is very common, it can be very severe also. And about 80% of patients can have more than one pain. But the good news is, about 75% of patients actually will get good pain relief when we go with the WHO ladder. So we start with step 1, go to step 2, and then reach step 3. About 75% actually will get good pain relief. The 20% of the patients are a struggle for us, and this is actually for both cancer and non-cancer patients. 10% of patients, the pain is very, very difficult to control, and that's what we're dealing with in this session. Next slide. So first question, what do you think could be the cause of our patients' uncontrolled pain? Is it because the pain is not responding to opioid, or any patient's uncontrolled pain? What could be the reason? Is it because the pain is episodic or breaks through despite adequate analgesia? Or is it caused by non-physical factors like psychosocial distress? Or is it all of the above? What do you think is the answer? Anybody can answer.
All of the above.
All of the above.
Well done, that's right. So next slide. So all these causes actually could be the reason why a patient complains of uncontrolled pain. It might not be an opioid sensitive pain, that could be one of the reason. It's something called a breakthrough pain. So we might be able to get on top of the background pain by giving her regular opioids, but we still won't be able to control the breakthrough pain. And that is actually, maybe that is disturbing her sleep, or that is making her distressed. Or it can also be caused by non-physical factors like psychosocial distress. Next slide. So we go into the 10-step evaluation process that I told you in the beginning. First step would be to believe the patient about the pain. Pain is what the patient says it hurts. Now this is very, very important as far as our specialty is concerned. And I just wanted to mention about one patient that I had to deal with after working in a hospital in Kerala. So this patient had got metastatic CA prostrate. He had bony metastasis. He was admitted under us. He was still getting radiotherapy, but he was admitted under our team for pain management while he was getting the RT. So he was on morphine infusion. He was on lots of stuff. He was on neuropathic agents. He was on high-dose steroids. We managed to get his pain under control after admitting him with infusion morphine, and he had a couple of settled days. One morning when I went to see the patient in the ward, he was in extreme severe pain overnight. It started overnight and it was episodic. He was getting it all the time. He was in distress. The nursing staff had to give lots of IV morphine. And then when I went to speak with the staff was telling me, actually, we're not sure what's happening. We gave lots of IV morphine. In between, we also pushed a bit of saline to it, and he responded to saline. So that patient was not a patient who would put up, he puts up a lot of pain, and that has never happened before. So I wasn't very convinced. So I went and took a history again. So what happened was, this time he's developed a new pain. So this time he's actually developed a colic. The pain was different. He had abdominal pain, he had colic. He had lots of RT to his prostate, and he also had constipation. So there was some evidence of subacute bowel obstruction going on. So clinically, what he had was a different pain. It was a colicky type of pain, which comes as a severe cramp and goes away. So, so even if they give saline or not saline, the pain would get better. The important thing is actually he wasn't putting on the pain. He was actually having a different pain, not responding to the morphine because it was a spasmodic, it was colicky pain, and a was coming and going, so probably respond to saline that way. So that's very, very important for us to know, to believe the patient. When we say that patient's got pain, we actually believe it, because patient says they've got pain, that means it hurts. That is one of the basic principles that we as palliative physicians always try to follow. Next slide. Step 2, correct any correctable factor. So as I said, look for the cause of pain. It can be a new pain, it can be a different pain, it can be, it might not be nociceptive pain, it can be a neuropathic pain. Can we do something to actually treat the pain? So if it's a new bony metastasis, can we give some radiotherapy? Can we give him more chemotherapy if we can have that to get the pain under control? Or further surgery? If it's a new abscess, can we drain the abscess? If there's an infection happening, can we give some antibiotics? So all these things we need to think, even if the palliative medicine physicians, in terms of, is there any correctable things happening? Another one is hypercalcemia, so bones, that can cause severe bony pain. So do the bloods, is there anything correctable going on? Can you treat the hypercalcemia and see the pain will get better? Next slide. Step 3 is check adherence to treatment. So our patient was telling that when we increase the morphine to 15 milligram Q4 hourly, she wasn't very keen. She wasn't happy with the treatment. This sometimes happens for all our patients also. So one of the study that was done to find out why the patients not taking adequate opioids found out lots of reasons, lots of factors why the patients are refusing to take the medications. It could be ignorance about the disease and the pain. So the patient has got, sometimes they don't even know they've got cancer. Some patients are there who doesn't know they've got cancer because the family doesn't let us tell them. So when the pain becomes very, very bad and we ask them to take morphine, they wonder why. Because they don't know they've got cancer, so they don't know why the pain is very bad. So ignorance about the disease, ignorance about the cause of the pain, that could be one of the reason. Sometimes they think that the medication is not effective. So suppose we're giving them a low dose of morphine and we're not titrating it up, it doesn't take the pain away completely. Then they might think actually the morphine is not working. So it's not the right dose. So they might believe that the medication is not effective. The frequency of daily dosing, so taking the medications every 4 hours might be too cumbersome for the patients. That might be one of the reason. Anxiety, depression, the psychosocial factors, high levels of emotional and psychosocial distress, lack of faith in doctors and health services that can happen to any patient. Financial problems, an important thing that we need to consider working in India about our patients and the financial issues. Loneliness, unsupported relationship, there's nobody to look after them, nobody to remind them to take the tablets on time. They have to do it by themselves. They just don't want to do it anymore. Again, the fear of adverse effects, the most important thing that we face, especially with opioids, how to talk to them about the adverse effects and how to actually allay their fears and to dispel those fears and myths about adverse effects. Negative cultural and religious belief. Some people just won't, they feel that the pain sometimes God's punishment, they don't want to take it away. They'd rather bear the pain than take morphine. The cultural issues about not treating the pain. Problems with doctor-patient communication. Another important thing. We make sure that when we start a patient with morphine, we spend at least more than half an hour or 1 hour with them, talking to them from the dosage till the side effects, tell them everything about what to do if the pain doesn't get better. That is very important, the importance of doctor-patient communication. There's a problem with that. They might not take the medications. And some people just don't want to take any tablets. So it'll be too much. It might not just be one tablet. There'll be paracetamol. There can be neuropathic agents. There'll be too much of tablet burden for them. And that could be a reason why the patient doesn't wish to continue the medication. So our aim is to try and find out why if they're not taking any medications, why are they not taking medications? Is it any of these reasons that is stopping them from taking the medications? Next slide. Again, financial implications. So very important for us when we deal with patients. So if you can see that tramadol, if you 50 milligrams, it's tablet, costs about 30 rupees per day. Morphine is obviously very, very cheap. And fentanyl is the expensive one. Unfortunately for us, if the patient is not tolerant to morphine, then we probably will have to go to fentanyl or maybe methadone, which I'll sort of mention in a few slides, because we don't have any other strong opioids available. But for us, as far as we are concerned, morphine is the gold standard, available at least for us in Kerala and most part of the country now. And that should be the one that we should be starting. Also, if you consider the financial implication, go for morphine first. Next slide. Step 4, look for emotional factors. So as I mentioned in the previous slide also, important thing, anxiety and depression. Some patients, obviously with the diagnosis of cancer and everything happening in their life, can have a clinical diagnosis of clinical depression or anxiety that can make them sort of not want to take any medications. So that's the reason why the pain is getting worse. They're not taking medications, or even if they take the medication, the psychosocial symptoms are worse, that it's like a total pain. Rather than the physical pain, is the psychological distress that's happening. Ask them about the insight about the diagnosis and prognosis. How much do they know about the disease? Do they know what's happening? Do they know why they're having the pain? Do they know what the prognosis is? Do they want a better quality of life? Why are they not taking the medication? Is there something else? Why does the lady doesn't want to take medication? Is there something else in her mind? Does she think that she's towards end of life? Is that the reason that she's being given morphine? Is that in our mind? So we need to actually address all that and try and find the cause. Again, correct the correctable. If you feel that the patient is clinically depressed, then discuss about that, refer for psychological counseling, also start antidepressants if indicated. So always try and correct the correctable. Next slide. Step 5, review the treatment regime. So again, go back to the patient, take a history. What is the nature of pain? So try and find out. So Dr. Ashgopal in the previous session discussed about the types of pain. So they've got proprioceptive pain, and neuropathic pain. So how do you take it step about neuropathic pain? So ask about all the other features. Try and find out what's the cause of pain. Reconsider analysis. Can we add something else? Can we change the analysis, or can we add a neuropathic agent? And reconsider the adjuvant measures. Next slide. So the neuropathic pain management, which was briefly touched in the previous session, but I'll just sort of go on mentioning, because I think most difficult pain that probably when we clinically face usually has got a neuropathic component to it. And also when the pain reaches the chronic pain stage, they all seem to have a neuropathic component to it. So we still got a ladder, but it's slightly different. And this is targeted to just the neuropathic pain management. Corticosteroids do have a role. So it's a simple one which we can start earlier on. It will reduce the tumor edema. So if there's a big tumor compressing on a nerve somewhere, vehicle neuropathy, if it's compressing on the nerves and causing neuropathic pain, then a trial of steroids, high dose steroids, you can start with 6 milligram or 8 milligram. Liver capsular pain, steroids will work. So trial of steroids, if there's no contraindication, can be the step one, which will start working in 2 to 3 days and we'll get the effect quicker. Next step would be the conventional neuropathic agents. You can go with antidepressants or anti-epileptic as a step 2. Step 3, if the pain doesn't get better, you can combine the antidepressants and anti-epileptic. Obviously, if the steroids are not working, then there's no point in continuing the medication. You have to stop it if you feel that it's ineffective, because long-term steroids are not good choice for patients. So don't continue the steroids long-term. And then step 4, we go to the NMDA receptor channel blockade, which includes ketamine and methadone. Next slide. So which drugs do you choose for neuropathic pain? That's an important question, because now we've got a choice of medications. Previously, initially we started with just the tricyclic antidepressants, but now we've got different types of antidepressants as well as anticonvulsants. So the thing to remember is the costliest drug is not always the best, and always consider the finances of the patient. I did have a medical rep who come to see me with the brand name of Lyrica. Now Lyrica is actually very good. The pregabalins, Lyrica is supposed to be really good, and it's available abroad, and they've brought it in India. The cost is really different, but they claim to say that it is much more better than the other pregabalin, the generic pregabalin. I'm not sure that they've got trials to support that or not. The thing is, if patient can afford it, then it's fine. But if patients are not able to afford it, then go for cheaper options. And expensive treatment obviously will destroy the families and the next generation. So always you have to consider about that before we try and prescribe any medications. Next slide. Right. Next question. Which one of the following would you use first line to treat neuropathic pain? Will you go for amitriptyline, venlafaxine, duloxetine, or pregabalin?
Amitriptyline.
Okay, well then. Next slide. Good choice. So amitriptyline is still, I would say, the gold standard and the first line. Only, obviously, the patient has to tolerate it. But what I would suggest is, unless there's absolute contraindication to go with amitriptyline, always give it a try and see. The patient tolerates it, then well and good. If you don't tolerate it, the left side effects, and obviously we'll have to switch it. But go for amitriptyline as first line. Next slide. So these are the names of medications which the tricyclic is an SNRA group of antidepressant that is commonly used for to treat neuropathic pain. So we go with amitriptyline. We can start with 25 milligram and range up to 75 milligram HS. Imipramine is similar to amitriptyline. Sometimes we go for that because it's got fewer side effects compared to amitriptyline, so lesser anticoagulant side effects compared to amitriptyline. So sometimes we prefer that instead of amitriptyline. Nortriptyline, similarly, like amitriptyline. Venlafaxine and duloxetine are newer ones, so that sometimes I use like a step 3 for an antidepressant. So if it doesn't work with amitriptyline, very difficult neuropathic pain, then go for venlafaxine. And duloxetine as such has got a role in diabetic peripheral neuropathy, which I'll come to next slide. So it's actually a drug of choice for diabetic peripheral neuropathy, according to NICE guidelines. But for other cancer pain, we always go with the other amitriptyline first line before we switch on to venlafaxine and duloxetine. Next slide. Anticonvulsants. Again, we've got a list of anticonvulsants you can choose from. We usually go for gabapentin, which is cheaper than pregabalin. But obviously, gabapentin is, as you know, a thrice daily dose. It's a tedious dose, so it's more tablet burden for the patient. pregabalin we can give us twice daily dose, 75 to 150 milligram per day in divided doses. I sometimes go with lower dose. I start with 25 BD and go to 50 BD because some of our patients are not able to tolerate higher doses and there are side effects so that they won't take the tablets further. So I usually go with a lower dose and then work with them. But always with the neuropathic agents, which we discussed in the previous class also, the important thing for you to remember and to tell the patients is we start as a low dose and titrate up. So don't stop with 25 milligram HS or 10 or 25 amitriptyline or 25 BD pregabalin. No, the pain won't get better. Tell the patient it's a trial of starting at low dose and working the way up. This you need to convince the patients because I've had patients who had seen neurologists in the past for some neuropathic pain and they start on all anticonvulsants and the pain doesn't get better, so they come to us for specialist palliative care. But obviously we do the same thing. And on further questioning, we know that they can start on the basic dose of neuropathic agents, but they didn't go back to the doctor to titrate it back up because it wasn't working, so that patients decided to stop taking them because they felt it was not working. So it's that communication is very important to tell the patient that it might not start work immediately. You have to titrate it up, but don't stop it. Give it a trial, and if there's no side effects, we can titrate it up and to get the maximum dose to have a benefit. So all the neuropathic agents, we need to make sure you tell the patient that you start low and go up. Carbamazepine, again, drug of choice. So this is not an MCQ, but anybody can answer. The carbamazepine is a drug of choice. Particular neuropathic pain. Anybody can say that? It comes in the face. A particular neuropathic, not related to cancer, could be, but yeah, particular neuropathic pain that comes in the face and it's supposed to be a drug of choice. So it's trigeminal neuralgia. So up to date says that carbamazepine is a drug of choice. The only thing that we need to remember with carbamazepine is sometimes with Asian population, it's seen that the Stevens-Johnson syndrome is actually more common in our population with carbamazepine than the Caucasian population. Like, again, I've seen patients with a very bad Stevens-Johnson syndrome who start on carbamazepine. So it's something that we need to be aware of with our population compared to Western population. But again, it's also a good neuropathic agent, and sodium valproate can also be used. Next slide. So we've got a bit of evidence again which says, why did I say about tricyclic antidepressants or amitriptyline as first line for neuropathic pain? So there is an article that was published in 2009, which was a synthesis of recommendation from a meta-analysis of all the neuropathic pain agents. A stepwise approach to neuropathic pain. You go first line with tricyclic antidepressants, and next, if it doesn't work, or you can add on gabapentin or duloxetine or pregabalin. Next slide. This is a neuropathic pain algorithm, which was published in Northern Ireland Health and Social Care. As I mentioned before, diabetic neuropathy, the NICE guidance in UK specifically says duloxetine is a drug of choice for diabetic peripheral neuropathy. So only for that, you go first line with duloxetine. And if duloxetine is contraindicated, you go for amitriptyline. Any other cause of neuropathic pain, always go for amitriptyline first line. And if it's contraindicated, then go for pregabalin. If it's not tolerated, if its side effect profile is a problem, then probably go for mipramine or venlafaxine. Personally, I would actually go for even without this, I would actually go for neuropathic antidepressants as neuropathic agents if the patient has got sleep issues and or maybe you think there's an anxiety or a depression issues, psychosocial issues in the background. Always we should go for antidepressants. It's a first choice in neuropathic pain than pregabalin. Next slide. Again, this is quite recent guidelines. WHO has published recent guidelines for the pharmacological and radiotherapeutic management of cancer pain in adults and adolescents. They have mentioned most of the medication that's been tried for the. It's an interesting read. That the guidelines is quite interesting to read. They've actually mentioned most of the medication that's been tried, and they've also said which has got evidence and which doesn't have evidence. And most of them, what they've suggested is they do not recommend or they do not say against it. So basically, they left the choice to the clinicians to use it. So what they've told is there's not enough evidence for superiority and safety of gabapentin or pregabalin over amitriptyline. So it doesn't mean that you can't use gabapentin or pregabalin. It just means that amitriptyline is the first line treatment for neuropathic pain. The other one is not superior to amitriptyline for that. Similarly, when we read further on the guidelines, they have mentioned about what evidence they have got for bisphosphonates and radioisotopes and all those for bone pain. Everything they've actually divided into evidence base and said and given suggestions to use and not use. So WHO guidelines also goes in favor of amitriptyline as a first-line treatment for neuropathic pain. Next slide. Okay. So since the topic is about typical pain management, I will have to mention something about lignocaine infusion. It's not something that we commonly use in palliative care. Obviously, it's a very, very difficult pain to control. There are specific indications and specific scenarios where we can always use it. You can give it intravenous and subcutaneously. And the guidelines says that a specific indication for lignocaine infusion, severe cancer-related neuropathic pain syndromes, which is inadequately responding to standard therapies. So obviously the standard therapies will include the opioids, paracetamol, the neuropathic agents, everything that we normally try for neuropathic pain, we should have tried them all, and the pain is not getting any better, and the patient has got very, very bad intractable pain, then we can use lignocaine infusion. But it's not an easy step to use it, and we should have experience as well as the setup to use it. And also for pruritus, they have shown some evidence for lignocaine infusion, obviously severe intractable pruritus, because whenever we use a medication, we have to look at the risk and benefit of giving it. There are some related contraindications, and there are some absolute contraindications also for not using lignocaine. So related contraindications obviously will be the clinician's judgment of the risk and benefit. So it has got some significant cardiac disease, some heart blocks, significant liver impairment, hypertension with BP systolic is more than 160, or the patient's already on some other sodium channel blocking agents or any antiarrhythmic agents, amiodarone or beta blockers, then it's advisable not to use lignocaine infusion. So, but obviously, again, it's a risk and benefit balance. How bad is the distress of the patient and how bad is the contraindication? Next slide. So next question. So I mentioned related contraindication, but this question is about absolute contraindication. Which of the following is an absolute contraindication for lignocaine infusion, where you shouldn't use lignocaine infusion? So is it hypotension? Is it hypokalemia or hypomagnesemia? Is it previous stroke or renal failure? Anybody?
B.
Sorry?
Hypotension.
No?
B. B.
Hypomagnesemia. Good.
Hypotension.
No, it's not A. It's not A.
B. Ma'am, doctors here say it's B.
No, renal failure. Renal failure.
Okay, it's B. B is the correct answer. Which doctor said that?
All the doctors.
Renal failure. Renal failure.
No, it's hypokalemia and hypomagnesemia. Next slide.
No, renal failure. Renal failure.
Yeah. Sorry, next slide. Okay, the guidelines says that usually it's hepatic failure that's problem with lignocaine because hepatic metabolism. Hypokalemia and hypomagnesemia are the absolute contraindications. It's epilepsy, not previous stroke, and hepatic failure. And this one caused hypertension. So next slide. So absolute contraindications with the do not use lignocaine is prior allergy to amide local anesthetics, hypokalemia and hypomagnesemia, prior history of epilepsy and unexplained seizures, and heart blocks. So intra-auricular heart block is not managed by pacemaker, both Parkinson's syndrome, Stokes-Adams syndrome. Stokes-Adams syndrome is like a syncopal episode in the past, diagnosed, already diagnosed. Patients diagnosed with the falls and syncopal episodes and because of cardiac history or cardiac problems, then it's advisable not to use lignocaine. That's an absolute contraindication, then you shouldn't be using it at all. Next slide. So how do you give it? We can give it both subcutaneously and intravenously. What I'm used to doing is subcutaneously, so I've given that in detail. So basically, it's a subcutaneous infusion in a syringe pump along with normal saline. So you take lignocaine, Silocat 500 milligram in 5 mils, which is 100 milligram per mil undiluted lignocaine, and the dose is 0.5 mg per kg per hour. So 80 kilo will be 40 milligram per kg per hour. You calculate the dose for 24 hours, and you load the syringe with the 24-hour dose, you dilute it, and you start at 1 ml per hour to cover the same total dose to go over 24 hours. And it can be given as subcutaneous infusion. And you have to, the idea is to change the syringe every 24 hours, make a new volume the next 24 hours, and also to change the site of infusion, because you can have, irritation to the subcutaneous site. So ideally to, change the site of infusions. Intravenous infusions can also be given. I have never done that, but literature says you can do it, but has to be done in monitoring. You give 1 to 5 mg per kg IV over 1 to 4 hours. That is a bolus dose. That goes for 1 to 4 hours, and if it works, then you can actually convert infusions, intravenous infusions also. I think in palliative care settings, we always go for subcutaneous route. We prefer that. So all the guidelines and those are calculated in that. Next slide. There are a few things we have to monitor because you're giving liquid infusion, and that's why it's important to know where you give it. So prior to you start the infusion, get an ECG for the patient, get the BP, the heart rate, respiratory rate, the pain score, and the sedation score. And what they advise is every 15 minutes in the first hour, do the BP, heart rate, and respiratory rate. Then 2 hourly, 4 hourly, 6 hourly, 8 hourly, 10 hourly, and 12 hours. So obviously, it has to be a hospital setting if you're doing this. This is the ideal guideline where they say BP, heart rate, respiratory rate, pain, and sedation score. Thereafter, after that, the patient's stable, then you can go 4 hourly observations of the pressure, heart rate, respiratory rate, pain, and sedation score. And ECG can be repeated up to 24 hours. Again, just like opioid having opioid toxicity, there are a few symptoms that you need to be careful about to monitor for nicotine toxicity. You've got perioral numbness and tingling. You can have a metallic taste, so ask the patient about that. Tinnitus, ringing in the ear, paresthesia, drowsiness, hypertension. Hypertension is a contraindication, and BP can show up quite high and lightheadedness. And obviously, when if a side effect, so if toxicity develops, stop the infusion. And if the patient gets better, then you can actually restart at a lower dose if you find it's beneficial for the patient. But obviously, if it's a very, very bad toxin, then you will stop it completely. Allergic reactions and all. And obviously, the symptoms doesn't get better, then you have to stop it completely. Next slide. Okay, this is just a single slide about what the other adjuvants which can be used as secondary analysis. So I mentioned about corticosteroids. So steroids have got a major role in palliative care, as probably you must be aware now, as an adjuvant for pain of different sides. So a patient having raised intracranial tension for very bad headache, not suitable for radiotherapy, not suitable for surgery, or even if it's brain mets and you're not doing anything, they can have a course of steroids. So corticosteroids, high dose is very good for that. Back pain, secondary to spinal cord compression, they can have radiotherapy, but immediately you start steroids to treat it. Bowel obstruction, having very bad abdominal pain, again, conservative management bowel obstruction, we go for corticosteroids as a high dose 8 milligrams we can be for that pain. Liver capsular pain, I mentioned earlier on, again, for anti-inflammatory purpose, you can do corticosteroids. So steroids as an adjuvant, as a secondary analgesic, a lot of role in palliative care. Then, if it's a spasm, if you need muscle relaxants, baclofen is an adjuvant that can be used as a secondary analgesic to manage any difficult pain that's caused by spasm. So antispasmodic muscle relaxants. Antispasmodic, anticholinergic in the stomach. So anticholinergic and buscopan, hyoscine, glycopyramide, they are adjuvant analgesic, secondary analgesic can be used. Antibiotics. So why do we say that? Patients having a very bad oral fungal wound, oral wound, it's secondary infection, that is causing the pain to get worse. A trial of antibiotics can act as an adjuvant analgesic to bring the pain down. Antacids, so gastritis is the cause of pain, antacids is a secondary analgesic. Then, what about bone pain? So this is what I was mentioning in the nice WHO guidelines in 2019, which has mentioned we know the role of palliative radiotherapy for bone pain. So there's a new site of pain for the patient. There could be a new lesion. You can get an X-ray. You find a new lesion which hasn't had any radiotherapy before. So that is an important thing. They can have further one shot of palliative after to that site. So the important thing is to find out, is it a new pain? Is it a new bone lesion? Bisphosphonates have proven to have a role in the pain, in bone pain. So both they're used both as a bone protecting agent as well as to prevent the skeletal events in CA breast and CA prostate, as well as to get the pain under control. So bisphosphonates have a role for bone pain. Radioisotopes and monoclonal antibodies, so things like denosumab for against CA breast and CA prostate. These have got lots of evidence, but WHO says, it says a standard statement of it doesn't support or it doesn't go against the evidence of all these. So it's got some evidence, but probably the reason they not give us a first line is to actually do financial implications of the patient. So these are mentioned. If the patient is appropriate to treat them, then you can go for radioisotopes and monoclonal antibodies as secondary analysis for bone pain. Next slide. Okay, step 6, opioid switch. So again, we know the gold standard is morphine, but sometimes some patients don't tolerate morphine, but they might tolerate under opioid. Now, this we might realize when we are gradually increasing the dose of morphine, we realize that patients have side effects. Sometimes when they immediately start morphine, they have very bad nausea, vomiting, which is not settling with any anti-emetics that we give, very bad itching, or any reason the patient is not able to tolerate oral morphine, then it's worthwhile to see whether an opioid switch will work. But having said that, it's important to remember, one is fentanyl is very, very expensive. Our patients might not be able to afford, and it might not be available everywhere also. Some of the centers in, I think Kerala has fentanyl now. It's got a special license, which is different to the morphine license, I think. So then it's quite expensive also. I've used fentanyl in Kerala, so it's available in our hospital in Abatha, but I'm not sure whether it's available everywhere else. Methadone, again, Rajagopal has used it, Paliminder of similar has used it. It's very good. It's cheap also, good in renal failure. But methadone as such would be a different talk, because that needs lots of lots of specialist advice about how to use methadone. So it is a good one for opioid switch, and that's the other step to opioids available in India. Next slide. Next slide. Okay. So why does some patients don't tolerate morphine is when you know that the morphine metabolism, morphine glucuronidation happens, and we get M3G and glucuronidate and M6G-glucuronidate. That is the analgesic effect. M3G actually causes side effects, and no morphine and the other metabolites also happens. Next slide. What happens is some patients have got genetic predisposition to generate more of M3G, and that will cause poor tolerance to morphine. And that's the reason that some patients actually don't metabolize or has no side effects with morphine compared to the other patients. Next slide. Okay. Step 7. These are a role for interventions, and these are a role for non-pharmacological measures. So we have talked about all the most of the medications that we can try, and in some specific patients, there is a role for interventions for pain management, especially for neuropathic pain, and there are roles for non-pharmacological measures also. Next slide. This is a list of analytic techniques that can be used. This is from a BMJ that was in 2006. So some of these are quite old, and lots of new procedures have also come. So basic things are either a peripheral nerve blockade or central nerve blockade. And depending on the site of patient, you can have an intercostal nerve blockade. You can have mesothelioma pain. You can actually have intercostal nerve blockade. You can have femoral nerve blockade, sciatic nerve, brachial plexus blockade if the the lesion is in the axilla. Psoas muscle blockade. You can also have paravertebral sensory neuron ablation, celiac plexus blockade. Everybody has heard about that. CA pancreas pain. You can have the procedures done in the spinal cord, which can be non-destructive ones and destructive or neurosurgical ones. So everybody, I think, mostly in pain interventions use epidural anesthesia or vertical pumps is also quite common. I think some of the centers in India quite frequently use that. The Medtronic pump is quite available in the pain centers. There are specific cancers, specific pain which would benefit from this vertical pumps, and patient selection is most important for that. Some patients benefit with cordotomy, so they're actually ablating or destroying the nerves in the spinal cord. RF ablation, radiofrequency ablation, vertical phenol. So all these procedures have a role in our patients. The important thing is selecting the right patients for the right procedures. Next slide. What are the non-pharmacological things that you can try? The Oxford textbook of palliative medicine has got an entire chapter dedicated to complementary therapy for pain management and all the non-pharmacological stuff. So you can refer the patient to physiotherapists. They will be able to teach exercises. Some patients with the muscle spasm, get taught right exercises to relax the muscles, the pain can get better. Heat therapy, massage with spasm, psychological techniques to refer for a CBT, cognitive behavioral therapy for relaxation, hypnosis, and biofeedback. TENS, some physiotherapists actually use TENS to manage pain. Acupuncture, again, evidence-based for some specific type of pain. Acupuncture has a role. And capsaicin cream is, I'm not sure whether you've heard of that. It's basically it's chili pepper. Chili pepper is a the mechanism is a counter irritant. So some, some neuropathic pain, which is like a post-hepatic neuralgia, or an area of neuropathic pain in the leg. Sometimes you can use the capsaicin cream as a local irritant to apply over that area, and the pain might get better. But again, it's highly irritating. It's like a chili pepper, so you have to be very careful when you use that. So advise the patients about that. Next slide. Okay. Step 8, want to consider is alternate route of administration. Do you think some people respond better to a parenteral morphine compared to oral? This we always sort of tell about the benefits of oral morphine. There are some situations where parenteral morphine is useful or better than oral morphine. And examples are absorption issues, patients with bowel obstruction and not able to tolerate oral medications, and you can try for parenteral morphine. The other thing is sometimes for very quick pain relief, sometimes you can do IV morphine trial, and that might act quicker. So you can actually give parenteral morphine instead of oral morphine. Patients vomiting, again, they're not able to absorb the oral morphine, so go for parenteral morphine. Okay, so I'll be covering about the last step about the ketamine. So again, sir mentioned in the previous class about the previous slide, for central sensitization. When they use the chronic pain stage, you know that they reach a stage called central sensitization when the neurotransmitters are released and you get something called a total pain, the central pain. So NMDA antagonists will reduce central sensitization. It acts on the spinal cord. Next slide. So the important one that we discussed today is about ketamine. So we go for step 9, beyond the ladder, you can try ketamine. Ketamine and methadone are 2 NMDA blockers. You can try something called ketamine burst therapy. The indications of ketamine, which is actually an anesthetic, so all the indications using palliative care is unlicensed. We can use ketamine for neuropathic pain that's poorly responsive to opioids for the oral adjuvant analgesics. For any sort of complex ischemic limb pain or phantom limb pain, you can use ketamine. Poorly controlled instant bone pain, which sometimes has neuropathic element to it, so you can use ketamine for that. And complex visceral and abdominal neuropathic pain. Next slide. Burst ketamine is when we use ketamine as in a syringe driver, as a cutaneous pump. So basically, the idea is to start this 100 milligram of ketamine over 24 hours via syringe driver subcutaneously. If that dose is effective, this can do any type of neuropathic pain. If that dose is effective, you continue that for 3 days and you stop it. So basically, the pain gets better in 24 hours, but you continue for 3 days. It's supposed to block all the NMDA receptors and you stop after 3 days. If suppose the 100 milligram is not working, after 24 hours, you increase the dose to 300 milligram, again continue for 3 days and then stop. If 300 is not working, after 24 hours, keep 500 milligram. After 500, you don't go higher up than that, but always stop ketamine at day 5 whether it's effective or not, or significant side effects occur. So this is the principle of burst ketamine protocol, and it's usually done as subcut. Oral ketamine is also available in some centers, and it can be used in some home setting in developing countries. Again, the metabolite of oral ketamine, norketamine, is believed to be pharmacologically active, so the first pass metabolism makes the oral route more efficient. And usually it's the same IV preparation is used as the oral preparation. Doses 0.2 to 0.5 mg per kg, Q8 hourly to Q6 hourly. Next slide. Just like the subcut ketamine, there's a protocol of how to do oral ketamine. You can start at 5 to 10 milligram 4 times a day, increase the dose to 55 milligram increments, and the usual dose is in the range of 10 to 16 milligram 4 times a day. Next slide. Okay, last question for the day. Which of the following is not a side effect of ketamine? Is it psychotomimetic phenomena, hypotension, delirium, or diplopia?
Hypotension.
Well done. Next slide.
Hypotension.
Yeah, that's right. Next slide. Yeah, you're right. So basically, it causes hypertension and not hypotension. Next slide. Side effects of ketamine, you've got hallucinations, dysphoria, vivid dreams, that's psychomimetic symptoms. You get hypertension, tachycardia, and raised ventricular pressure. You get sedation at higher doses, eczema and pain at infusion site if you're using subcut ketamine. So if you get the psychomimetic symptoms, it's always advisable to start haloperidol along with ketamine at low dose 0.5 milligram. You can also give, sometimes you have to use the benzodiazepines also to help with the symptoms. Some patients will get some cystitis, which is not infected, so you can track symptoms, frequency, urge incontinence, and hematuria. There has been case reports of drug-induced liver injury following overdose of ketamine for CRPS patients. So we need to be careful about that. Next slide. The last and final step is, in spite of all our medications and all our trials, pain is not getting any better. We have to accept that the patient has to accept it. We're not God. We need to learn to accept failure as symptom control, but always support the patient. Talk to them, tell them that we're not just giving up on you. We're still with you. We'll try our best. And maybe at that point, we might have to start talking to patient and family about palliative sedation, because most of the patients at this stage, or patients like this, who's got very difficult pain to control, usually end up having palliative sedation. Next slide. Just one slide about palliative sedation. Again, it's a chapter in Oxford textbook. I've just selected a few points about whom it's used for. Basically, patient will have a severe, chronic, life-threatening illness. There's a list of illness in that. Patient must be suffering from one or more severe physical or neuropsychiatric symptoms, which is not responding to any standard palliative intervention, which could involve including interventions and all the treatments that you can think of. Patients are responding to that. Comfort is overriding goal for the patient care, and where possible, there should be an active order. So they should be having something like not for resuscitation order must be there, not for life-sustaining treatment order must be there for the patient. You should get informed consent for palliative sedation, which mentions that it can actually unintentionally hasten death. Must be obtained in advance of the patient, and also staff members caring for the patient must be aware of the fact that they're going for palliative sedation. So everything should be documented and everything should be communicated to the patient and family. Next slide. So to conclude today's presentation, 10% of patients will have difficult pain. So you will probably meet a patient in your career who has got a very difficult pain. Evaluate the patient with a 10-step process that we discussed about. There's a role of adjuvants depending on the type of pain. Lidocaine, ketamine, and methadone can be tried depending on the clinical picture, and always discuss palliative sedation if needed. Thank you.
Thank you, Dr. Sunitha. And it's time for doubts. So anybody has any doubts on this presentation? Any points you want to clarify, please ask.
Good afternoon. This is Dr. Anshika.
Yes,
Can I ask a question? I recently, in fact, have a patient admitted. He's a around 60-year-old gentleman with splenic colon growth, which is metastatic to liver, malignant ascites, pleural effusion involving pancreas. He presented with quite a lot of pain and quite a lot of ascites. So initially, I gave opioids as well, but his pain got relieved after the ascitic tap. Of course, it had to be repeated every 48 hours, and we try to restrict the number of ascitic taps. So, could you have a comment on that? Ascitic tap.
Yeah.
Yes. Anybody, Sunitha, just wait. Anybody else has any comments? Wait. Yeah. Just okay, we have a palliative medicine consultant from US, Dr. Marcia Glass. She's an associate professor, so she would like to comment on this.
That was a great presentation. Thank you so much, Dr. Daniel. And it's quite advanced. The material you covered. I just wondered, for lidocaine infusion, have you been able to do that frequently in India? Because in the US, at my hospital, they won't let me. So I wondered if you could comment if they're doing it in India and where.
Okay. In India, where I was working is the hospital, and our palliative care unit was started. Obviously, by Raj Goba, he's an anesthetic. Can you hear me?
Sunitha, your sound is breaking.
Ma'am, you can disable your video.
Okay. Okay. So, can you hear me now?
Yes,
Yeah,
ma'am.
better.
So, the unit where I was working was started by anesthetists and is still led by anesthetists, and they're quite confident in using lidocaine infusion. So we had, and it was in a tertiary hospital with an ICU backup if needed. So I think, in such a setting, it's possible for us to use lidocaine infusion, but not for all the settings. So because I was working in a setting like that, I was able to use it here.
Thank you.
So, Sunitha, do you want to comment on what Dr. Anshika asked on ascetic tap and
Yeah,
pain
that's-
management?
Yeah, I think that's a very good clinical picture and very good point also for difficult pain control. So patient has got ascites, and that is contributing to the pain. And rather than giving opioids, we're tapping them was the right decision. The only thing that I was thinking was, I'm not sure whether in your setting whether maybe things like permanent ascites brain or whether the patient can empty it at home. If that's a possibility, then that might be the better option rather than increasing the medications. If ascites draining, the ascites is what's needed, then put a catheter drain, a pigtail catheter drain, and come to the bag and teach the family how to drain it at home. That's a possibility.
Thank you. Anybody else? Anybody else has any comments or questions?
Can I ask one more question, ma'am?
Yes.
I wanted to know regarding amitriptyline titration. So after how many days, like we start at 12.5 or 10, and then we titrate upwards. So how many days of gap would you recommend for titration of amitriptyline?
So, anybody?
I would like to answer this question.
Yes.
Amitriptyline 12.5 can be continued if the patient is responding very well. But for about 5 days, we can try 12.5. If not responding absolutely 100%, then only we can increase. But nevertheless, amitriptyline is also good, and we can stay with that forever rather than going for gabapentin or the higher ones.
Okay. Sunitha?
Yeah, I think that's fine. So amitriptyline, if the patient tolerates that, and what I've clinically seen is most of patients in our population just need a lower dose of medications to actually get the pain under control, which is true for morphine, including morphine, all the other antidepressants and anticonvulsants. What textbook that we follow is obviously PCF4. PCF goes with the Western data. But clinically, if you go with our patient population, 10 milligram or 12.5 of amitriptyline might be enough to take the pain away, and that's fine. If not, after 3 to 5 days, you can make it up to next higher level and see. So I agree with what the other doctor has said.
Thank you. Anybody else?
Dr. Glass, another question is okay?
Yeah.
Dr. Daniel, at your center where you are doing the lidocaine infusion, are you also doing continuous ketamine infusion, or are you just using stat doses for the ketamine?
The ketamine, as I said, we have done with the burst ketamine, so that will go for 3 days, and then we stop it. So I don't do the bolus ketamine. The ketamine I started doing in UK, and I did the same practice after I came back to India, and that was subcut ketamine. There was a patient who had very bad neuropathic pain, not responding to anything. So what I did was the burst ketamine as a continuous infusion. We didn't have to increase dose, so we started with 100 milligram, and I did that for 3 days, and the pain got better.
Okay. Thank you.
Do you have any comments or questions? No, she's not here.
Where is,
She's not here.
but where is your hospital where you're doing all these things?
It's in Kochi. Are you coming to Kochi by any chance?
You're in Kochi?
Wow.
Yeah, it was in Kochi.
Asking so I can send some American doctors to learn from you.
Oh, right, okay. Unfortunately, I've left that place now, so I'm not working there anymore. But obviously, there's other doctors there who will be happy to help you. At the
Great. It's very advanced treatments you guys are offering. So, yeah, thank you.
Do you have any comments or any comments on?
No, it's just so funny to me because I go to the pharmacy committee in my hospital, and I literally said, some American hospitals are doing a lidocaine infusion. Can we do it? And they looked at me like I had completely lost my mind. And they just said, what are you talking about? We can't do that unless we run a code blue. And I said, no, I'm not talking about, VTAC. I'm saying this can be used for pain. And they just really thought I was crazy. And in the ketamine, I tried one time to run a continuous infusion, and they brought 5 vials of ketamine, and they said, this is all we have in our hospital, which was enough for about 3 doses.
Yeah, but that's very interesting because ketamine is something that we do. I did in hospice in UK. So you know how hospice are? You just basically barely have a crash card with the defib that is like the automatic one for the family, not for the patient. And so the ketamine that we did on hospice was on a multiple sclerosis patient having this very bad pain that will just respond to ketamine alone, nothing else, with no backup at all.
Yeah.
And not even a cancer patient. So it's, I think it's depends on where you work. It's quite important, isn't it?
But in California, they like to use ketamine, and we could just run it in the regular medicine floor. So it depends where you are regionally.
Yeah, exactly.
Yeah.
In summary, we had talked about 10 steps in managing difficult pain, which includes many things, but basically checking compliance is one of the important factor, which we usually don't do. And we write many medication without considering the financial status of the patient, including gabapentin and pregabalin. And usually the patient will not take those medication because of financial reasons, and they will come up with uncontrolled symptoms, and we will again escalate the medications, and they will again end up with increased pain. So it is very important that we should also see the pharmacoeconomics. Then there are some medications which can be or opioid switching which can be used. In India, the options are fentanyl and methadone. That also fentanyl, methadone is only used by very few centers in India. I think only 4 or 5 centers. Fentanyl is another option, but you have to understand that it is also costly. Then in the metabolism of morphine, formation of M3G and M6G is also important because it is metabolized in liver, and sometimes some patients produces more of M3G than usually M3G is produced more in more quantity, but in some patients it will be more than the usual, so that the effect of M6G might be less. In such patients, IV infusion or subcutaneous infusion might be helpful. And emotional factors is something which we usually neglect because we usually concentrate on physical pain, so that the emotional pain will add on to the physical pain. So you have to actually listen to the patient and address the emotional issues of the patient. Then there are some medications which or some analgesics which has to be used depending on the nature of the pain. Is it neuropathic pain or nociceptive pain? Then special medications like lignocaine or ketamine can be used depending on the situation in uncontrolled neuropathic pains. And finally, acceptance is what the final step is. And there will be some patients who has no relief with your analgesics or interventions, and in such situations it is important that you should convey the message that we care for you, because we have some chronic pain patients, and we have tried many things, but they don't have relief. In such patients, they want to come and visit us. In such situation, we might tend to not to see them. So it is not like that. You have to see them and listen to them each time they come, so that they will feel that there is somebody to um, somebody for to listen to them. So it is important that you should communicate the message, okay, I care for you, even though we accept that we are not gods. Okay.
So I think we can move on to a case presentation now. Dr. Anshu. you want
Yes,
to-
ma'am.
Yes.
Hello.
Hello, we can hear you, ma'am.
Yeah, okay. Good afternoon, everyone. Myself, Dr. Anshu, Lady Medical Officer in Navoko Health Center. I am from Chhattisgarh. My patient is about a 47-year female patient. Her diagnosis is carcinoma of right breast. Staging is T3 N0 M0 AR negative, PR negative, HER2 equivocal. Next slide. Presenting complaint when she was come to me at the time in last year June 2018 it was. She is having complaint in pain in right side of the breast and with the palpable lump and the duration of lump and pain is since last 1 month. She told me like she is not having any history of fever or any history of trauma, and she was not a known case of the hypertension and diabetes mellitus. Next slide. History of illness was just for short duration, that is of last 1 month only, she told, and presence of lump was also from since last 1 month, and she was 47 year of the age, but menopause doesn't occur at that time. On examination, general condition was fair, afebrile, that pulse rate was 80 per minute, blood pressure 110 by 70 mmHg. On auscultation, that is respiration is bilateral chest is clear, CVS S1 S2 present, no murmur is there, concern consciousness and oriented, upper abdomen soft, non-tender, bowel sound is present. On local examination, it was around 6 into 5 centimeter lump in right upper quadrant of the breast, right side of the breast. There is a no lump palpable in breast, but when it was like left breast is not no lump palpable, but in right side there is palpable. Bilateral normal axilla and bilateral ascending is normal. Next slide. During the course of treatment and the investigations, CBC routine blood all routine blood checkup was done. CBC hemoglobin was 12.7, TLC 10,800, neutrophil 68, lymphocyte 24, eosinophil 4, mono 4, ASL is slightly elevated 32. Platelet count was at that time 1.85. Our random blood sugar is 89, urea 20, creatinine 0.8 mg per deciliter, sodium 142, potassium 4.2. Bilirubin is within normal range. SGPT is 24, SGOT is 28, serum alkaline phosphatase is 58, total protein was 7.8, albumin is 3.9, globulin is 3.9, albumin globulin ratio is 1.0. That time PTR had PT is 13.5 second, control was 13.5 second, INR is 1, ratio is 1. Anti-HCV is non-reactive, HBS antigen is non-reactive, HIV1, 2 both are non-reactive. Bilateral sonomammography was done. In that, altered echo pattern in the right breast in both outer quadrants that carries fibroadenomas, maybe neoplasia. Some small hypoechoic lesion is in left breast, carrying fibroadenoma. It was initially second week of the June, and patient came to me that was first week of the June, and FNSC suggested ductal carcinoma that was grade 2 to 3, FNSC from the right breast at the 10 o'clock position. It was on the same date of the sonomammography. And further, she went for the investigation, and CT chest was done. That is simplified heterogeneous lesion at the upper quadrant level of the right breast. That is neoplastic, and echo is normal. That CT scan is done on 22nd of the June. Next slide. Treatment given at that time, patient was advised for the plan for the surgery followed by the chemotherapy, and she has also given advice for MRM in between the MRM and breast conservation surgery, but she opted for the MRM, and she underwent MRM right breast on the 23rd of the June. That was by mistake 2019. It was 2018, and specimen sent for the HPE on discharge. She discharged on 25th, and at that time she advised medication. That first she advised Revivin OPD after 5 days for the drain removal, and advised medicine is Cetyl 500 mg, that is ciprofloxacin, 1 BD 7 days, levofloxacin is 1 tablet OD for 7 days, Sintodec, and that is for OD for 15 days, Paracet, that is BD for 3 days, and SOS, and tablet for that is 1 tablet TDS for 7 days. And after that she visited to OPD and drain was removed, and after that in July, 6th of July, suture also removed. After that, chemotherapy was planned with FEC from 17th of July to 30th of the October. She had 6 cycle of the chemotherapy, and in between these phases, menopause occurred in September 2018. Initially, patient was 47 years of age, but she doesn't had menopause, and after I think so 3rd chemotherapy, she had menopause. Next. Treatment and significant investigation also had histopathology examination, ER, PGR, IHC estrogen receptor tissue PB result occur. That is a specimen from the right breast, PR negative, new oncoprotein, IHC score is 2, equivocal in the ductal carcinoma in situ. After 3rd cycle, chemotherapy cycle, she had little bit pain in abdomen, and off and on fever also occurring. EOG abdomen done at that time, and that shows mild hepatomegaly with the grade 1 fatty liver. Echogenic foci in the urinary bladder, tiny napulin sit in the cervix. Now plan to give 3 more cycle after 3rd chemotherapy, and she received 2nd chemotherapy cycle with FEC on 19th of September with the growth factor and supportive treatment. That growth factor and supportive and injection interleukin was added after the 2nd chemotherapy. After 6 chemotherapy, patient evaluated with the CBC, LFT, RFT. There was within normal limit, and she underwent immobilized and CT stimulation on November 20th of November. And after that, she planned for the radiotherapy that was given EBRT, RT 50 days 25 till 22 of the December. And she advised for review in OPD in every 3 months. So she visited after that completion of the radiation therapy in March 2019, and she had CT chest. She advised for the CT chest and abdomen also, and it was in March 2019. In these reports, the status of post right mastectomy, no obvious demonstrable mass lesion or significant axillary lymphadenopathy, linear fibrotic opacities in the anterior segment of the right upper lobe, no evidence of the pulmonary or hepatic metastasis, mild hepatomegaly. That was after 2nd chemotherapy, or I think the 3rd chemotherapy in sonography is also there, and a small nodular sclerotic area in the left iliac. Next slide. Psychological aspects. Nuclear family, that is, and her husband is worker in cement factory, and after 3 years he will retire. Herself, she is housewife, and 3 children, in which one son is younger, 20 years of age, and 2 daughters are married. Treatment finances like self-paying they are sometimes, and sometimes they are having also cashless card, 1.2 lakhs. It is per year, so it's supportive for them, but still they are doing for from themselves also. And son is doing BBA. Next slide. Medication after each chemotherapy, she was advised tablet Granicet 1 mg 1 tablet for 3 days, tablet domestol, 10 mg 1 tab for TDS for 3 days, tablet Rantac 150 mg 1 tab BD for 3 days, capsule Bicocil 1 capsule daily for 3 days, capsule Oro for 1 capsule for 21 days, tablet Clogem to achieve BD daily throughout the chemotherapy, tablet Dolo 500 mg 1 tablet TDS for 3 days, chlorhexidine mouthwash TDS throughout the chemotherapy, syrup Dufenil 15 ml bed. If constipation will occur, before chemotherapy, she always advised for routine blood tests, CBC, LFT, and RFT, and injection Nukin 30 ml international unit subcutaneous edit after the second chemotherapy. And after radiation therapy, she advised capsule Bicocil 1 capsule OD and tablet Shalcal 500 mg calcium, that is calcium, 1 tablet for OD for the next 3 months. And she advised for the review in OPD after every 3 months. Next slide. The man concerning patient is concerned about that can I completely cure from this disease or it will again occur in left breast or any other organ. And my concern is in latest city, if we will notice, that was in March 2019, there was a small nodular sclerotic area in left iliac bone. So it may lead to metastasis or it may worsen. It is my concern. Next slide. The summary is carcinoma of right breast, T2M0M0, ER/PR HER2/neu, post MRM that was done in June, and post 6 cycle with FSC that was completed in October, and post RT 50 days 22 of the December. And there is now no locoregional post RT changes, and there is still now no evidence of the metastasis. Next slide. Discussion point is, as I already said, my concern about the latest CT scan, which was done in the March 2019. There is some small nodular sclerotic area in the left iliac bone. It may worsen or it may metastasis. It may get metastasized or what. It is my main discussion point. And also, if we concern from the patient point of view, then now she is okay, and she is visiting every 3 months to hospital. But is it cost effective follow for her? Like if her husband will retire, then a huge amount will be not given to them because of retirement. So if she will continue, then it will be okay, and if she will not continue, then how it may lead. And also one discussion point is what should we will do, that ideal frequency of doing CT chest, or we can say if she will have some complaint, we can say CT abdomen or bone scan or PET scan. So what should be the frequency of these all 3 imaginations? Thank you.
Thank you, Dr. Anshu. So anybody want to clarify anything from Dr. Anshu? Any doubts on the case presentation? So Dr. Anshu,
Yes, sir.
please tell me what was the insight of the patient? What is the insight of the patient? Does she know about the disease or?
Yeah. Actually, sir, when she came to OPD, we explained her, like she was very unknown for this disease, and in our area acceptance is not good. Like I'm suffering from cancer, it is very big thing. So she was initially not accepted. I already explained her. You have to go through so many investigations and so many imaginations, but she preferred firstly that mammography only. I told her go through the city, but she said, "Ma'am, I have little bit financial issue. I will go through initially some lowest price investigation." I told her, okay. Mammography was done. Then after that, oncologist consultation was also done, and after that she cleared. And if she is having any doubts from the oncologist, she asked me about her disease, like how will that whole treatment will go. So everybody explained to her, oncologist also explained to her, and I'm also explaining her, and she was the like acceptance came after that, knowing her disease, and she was like motivated. I will prolong my life, so I will do anything for my children, and I will do like my husband is also working, I will also spend some money, but I have to live like a normal person, and with quality of life. So she know about her disease. Initially we don't tell to her. Her younger sister came to me, elder sister, sorry. So I explained to her, then she explained to patient.
Okay. So you had three questions. One was on
Yeah,
sclerotic areas, and the
yeah,
other
yeah,
one was on how frequently the investigations should be done.
yeah, yeah.
And the third one was about uh,
Cost effective follow up, like in coming days she will definitely not able to do, as she is concerned about it also, because the main one mediclaim portion will be not given to them, because her husband will retire, soon retire from our that company.
okay. So we have some oncologists here. So
Yeah.
Dr. Gaurav, are you there?
Yeah.
Dr. Gaurav, can we have some comments on the sclerotic area and
No, I'm thinking here that we are actually jumping the gun.
okay,
So, considering the entire scenario which she has painted for us, I think that first of all, it is this CT scan wasn't warranted in the first place. We
okay,
should have got it done.
Okay.
Secondly, if we do know that she's got this sclerotic area in the left iliac bone, and if you're actually worried that she's got a metastasis, then I think, and if she's symptomatic, then only I would recommend to go for a bone scan. Or
Okay.
else, I don't think you should bother about this thing at all. Only if she's asymptomatic, then you should go for a bone scan. If not, ignore it completely. Secondly, you asked a lot of questions actually. I'll clarify each. First of all, she's both lucky as well as unlucky. She's a triple negative early breast cancer. So why she's unlucky? Triple negative have a tendency to come back in very strange ways. They come back in the bones in the brain. And why she's lucky? Because she's financing her own treatment. So she does not need to take any hormonal therapy. Hormonal therapies, they come cheap. But still, you're saying that she's paying everything out of her pocket. So hormonal therapy, Herceptin, both are negative. So sorry, the HER2 receptor both is negative. So she doesn't have to bear any cost for that. Thirdly, I would say that you wanted to know what is the frequency, because considering she has to pay for each of the visits comes to the hospital. So 3 monthly is the standard, at least for the first 2 years. Later on, we can increase it further. It can become 4 monthly or 6 monthly. Then it comes annually after the 4th year. And another thing which you said, that what investigation should we do? If she's asymptomatic and she's on regular follow-up, considering her actual case, you don't need to do any blood investigation, any imaging, nothing at all. She does not even require the calcium, because so whatever I've written, nothing. She does not need anything at all. Only she has to do is to attend the clinic, and examination will be done, and she comes back after another 3 months. So there's no role of any PET CT, there's no role of any CT scan, X-ray, ultrasound, nothing is required till such time she becomes symptomatic. Only if she becomes symptomatic, then accordingly we can prescribe any investigations. So that is what I would say, that means from her point of view, financially she should be, from this point onwards, it shouldn't be much of a stress for her.
okay.
Okay. Thank you, Gaurav sir.
Sunitha, do you have any comments?
No, I think
Yeah, like just what the oncologist said, reassuring the patient. The main worry is about
Sunitha, you are not audible now.
the oncologist.
I think
Yeah, we can hear, but your voice is very low volume.
Yeah, it's just
Yeah.
the main worry is about the sclerotic area and the left iliac bone. But it's been metastasized or not. So just like how the oncologist said, basically whether it's symptomatic or not, and reassuring her that if that's in her mind, then liaising with the oncologist and see what they think, and just reassuring her about that.
Okay. Do you have any comments? Okay. So I just noticed something in medication chart. Paracetamol was given in as TID. So,
Yes.
so the paracetamol actually the duration of action is 4 to 6 hours. So if you are treating for continuous pain or something like that, we should give it regularly to at least 6 hourly. So 4 to 6 hourly is the standard dosing time for paracetamol.
Okay, sir.
And also noted that Difalac is
Yeah.
lactulose, isn't it?
Uh,
And Anshika want to ask something?
Sir, I wanted to, sir, why don't you finish and then maybe I'll say something
Okay.
unrelated to
Yeah.
what.
So Difalac, which is again a costly medication, and some patients may not like the taste also. So why don't you give some tablets like Bisacodyl?
Bisacodyl.
Yeah. So it will cost less compared to Difalac.
Okay, sir.
Yes, Dr. Anshika.
Sir, I wanted to mention something about the surgery. So finally, this patient turned out to be early breast cancer, and turned out to be early breast cancer T2N0. Obviously, initially the imaging was T3.
Yeah.
And she underwent modified radical mastectomy, is what has been said. So I was just wondering, because in our clinical practice, we see a lot of post mastectomy syndrome, which is a constant thoracic and upper limb pain, which is more of a neuropathic pain. And it can go on from from the start of the surgery for up to 2 years and even lifelong. So Dr. Anshu, if you could assess her on that as well at her next visit, and
Okay,
maybe start medication for that. In my
Okay, ma'am.
clinical practice, whichever patient, I'm doing a complete axillary clearance, so I'm starting them on amitriptyline
Okay, ma'am.
at a low dose 10 mg. Another thing which we are also looking at is intraoperative lignocaine infusion, which is supposed to reduce the post-operative post-mastectomy syndrome. So maybe we could also look at her post-mastectomy syndrome status when she comes at the next visit.
Okay, ma'am. Thank you.
Just another comment, because she has two daughters.
Yeah.
Yes.
She has two daughters, so at least in the US, we would refer them all for genetic counseling. I have no idea if that is at all available, but at the very least, BRCA for everybody. But
So there are specific indications for BRCA testing. Of course, we all know that in India, because it's quite expensive. So only if those indications meet, only in those patients we
Okay.
counsel them for BRCA. We don't even counsel for that if the indications do not meet, because if they not able to get it done because of the costs, they feel even more guilty, and there is a lot of
Gotcha.
anxiety within the family.
Gotcha.
So we counsel them only if there is all the indications meet.
Okay. Yeah, we're finding other syndromes now. outside of BRCA, that they're linking as oncogenes. So it's becoming more and more common. But you're right. Even when you get the result that's positive, you then have to decide what to do about that. Because even it may not be 80% chance, it could be 30% chance. And then to get a mastectomy for that is a major decision. So even when we can do the testing, there's still very complicated implications.
So that's what, ma'am, the pre-test counseling is the cornerstone there.
Yeah.
So that will take care of all those issues later if it comes positive.
Mm-hmm.
Anshika, can you talk about the indications for doing this BRCA?
Sir, there are very specific indications. First of all, there has to be a very high risk in the family. So your first degree relative or a very low age bilateral carcinoma breast or carcinoma breast with ovarian cancer in the same patient or in the family. These are some of the few indications.
Okay. Thank you. So Sunitha, do you have any more comments?
Yeah, can I just ask that the medication slide? Okay, this tab graniset 1 milligram BD. Is it granisetron, the antiemetic?
Yeah. Yeah.
Okay, right. Is that what you use instead of Emicet or ondansetron in your setting? And isn't it quite expensive? I'm just curious why that came in the list.
Okay.
Is that what the oncologists prefer? I'm guessing.
Yeah, ma'am. Actually, she is creating from Apollo Hospital in our area. So different consultations are having different medications. So I think so. And in sometimes, ma'am, they are also thinking she is having cashless card, so we should prescribe like that. I think so.
Because I was not even aware that granisetron I've used in UK as an injection. We didn't have oral tab there, and I wasn't even aware that it's available in India. Obviously, it's likely to be very expensive. So, if at all, it's your choice. Probably go for something cheaper. Just my suggestion.
Okay. Sunil sir, I have one question from Anshika ma'am.
Yeah.
It is we are talking about the carcinoma of breast. So I have ma'am here one family in which her auntie, that is Bua is suffering from the breast cancer with lung metastasis, and she is under treatment. She is diagnosed in 2011, and till now she is in treatment, and symptomatic treatment she is taking, and she is also having cashless card. So if she is feeling anything, then immediately she used to visit hospital. And at that time, in that family, one girl, her mother is also had cancer in past. She had lung cancer with bone metastasis, and she's passed away after diagnosis 1 year 3 months. She treated and she passed away. So in this case, ma'am, her father side is also having mets, and the mother side is also having mets, but she is not having any problem till now, no lump in breast. Till now she is asymptomatic. So ideally, if she want to get some investigations, then after we change, like after 35, she can do like some genetic test. If we are talking about the BRCA, so I want opinion about in this matter.
Anshika? Did you get it correctly?
Rather than going for the genetic testing, if she is worried, then she could go for screening,
Okay.
For breast cancer, of course, there are age-related protocol. And if she's really worried, she could start the screening at an early age. Supposed to start only after 45. Younger than that, she could go for ultrasound of the breast, and I think that should be okay for married women. And after 30 years of age, pap smear for cervical cancer. For the lung cancer, the screening is not so great in India, but people are recommending X-ray, chest X-ray, digital, but it is not in the protocol yet. Then, of course, there are so many things, for each and every cancer. You can go for upper GI scopy, lower GI scopy. But right now in India, the screening is for breast cancer and for cervical cancer.
Yeah. Thank you.
Okay. So I think we have to stop the session now. So we talked about as we were lucky with oncologist with us. We were able to talk regarding when to do investigations for this patient and how frequently we should follow up this patient and what should we be looking for, like after mastectomy there might be chest pain or upper limb pain, and how to when to do the genetic counseling for another family member if there is high risk in the family. And we also talked about about pharmacoeconomics in this patient regarding granisetron and Difalac, and also about paracetamol need to be given 4 to 6 hourly. So that's the summary of this patient. So thank you, Dr. Sunitha, for joining us and for taking the session. And thank you all for today's interactive session. So we will see you next Wednesday with an important session on communication. See you on next Wednesday.
Thank you. Okay. Thank you. Bye.